Go ahead.
Okay, so the male factor infertility has now been ascertained to be a major cause of infertility in our environment. But globally, infertility is a reproductive health problem, but the burden has been shown to be higher in developing countries, even though the reporting is not well documented in our environment, but isolated reports have shown that male infertility is very much common in developing countries like ours. But the epidemiology is difficult to ascertain the exact figures of male infertility, being one of it's not a reportable disease, and mostly male infertility generally is treated as an outpatient, and therefore documentation is also a problem there. And then it's usually sponsored out of pocket, and therefore it's not reflected in many health insurance policies. The WHO estimate suggests that between 48 million couples and 186 million individuals live with infertility globally. And this with an incidence of 10 to 15 of all couples of childbearing age. And considering these figures, is about the third most commonly diagnosed disease after cancer and cardiovascular stroke, cerebrovascular diseases. Male infertility alone has been estimated to be about 40 to 50% causes of male infertility generally. But there are many reports around all, and that's why exact figures are not certain on male infertility. But one thing certain about most of the reports is that infertility is variable with multitude of influencing factors such as race, country, geography, and unique at-risk groups, many of which need further study to better characterize them. For pooled data from African countries, several data from various studies across Africa have been pulled and analyzed, and prevalence of infertility in sub-Saharan Africa ranges from around 20 to 40%. But in Africa, the prevalence of male and female infertility has been also analyzed to be around 54.1% and 22.2% for female and male related infertility, while in 21.36% of both sexes are involved, while 10.4% infertility were unexplained. The same thing also in Nigeria. There are several reports from actually all the geopolitical zones, which shows infertility being a common disease seen in many gynecologic and urologic clinics in various hospitals, and it accounts for the male impact to infertility is said to be responsible for about 40 to 50% of all infertility in Nigeria, although this varies from one region to another, and the causes also vary according to along this line also. In male, infertility is most commonly caused by problems in the ejection of semen, or it is in the ejection of semen absent or low levels of sperm, exospermia or oligospermia, or it can be from teratospermia or astenospermia. But aging has been shown generally to lead to a decrease in the quality of semen, and this has been documented in various studies, which predominantly affect the three parameters: the concentration, the motility, and the picture.
Our time.
Okay, classification briefly, infertility can be primary or secondary infertility. Primary infertility is when a pregnancy has never been achieved by a person. And secondary infertility is when at least one prior pregnancy has been achieved, irrespective of the outcome of the pregnancy. And full proportion of data also in Africa showed about 49.91% of infertility is primary, while 49.79 is secondary infertility. Thank you very much, sir.
Well, thank you very much. Am I clear?
Yes.
Yes.
Am I heard? Okay. So thank you very much, Dr. Musamil, for that. We took about a minute or two extra. We'll go next to the anatomy of the male reproductive system, and Dr. Magnus will take us through that. Again, 10 minutes. Over to you, Dr. Magnus.
Yes, sir. Okay. Good evening, my teachers, colleagues, and everyone. I'm discussing the male reproductive anatomy and physiology. I'm Dr. Magnus, urologist from Chiva Specialist Hospital. I'll be going through the outline. Sorry, it's not moving.
Click it, it will move.
Yeah.
Click inside it, then you click it to move.
Okay, thank you, sir. So I'll be going through these outlines, reproductive anatomy, go through the different parts of the male reproductive tract, then also reproductive physiology. As a word of introduction, a clear understanding of the male genital anatomy is very necessary so as to comprehend the normal reproduction of the male, as well as disease pathology and their treatment options. The male reproductive tract has an external genital and the internal genital organs. The external genital consists of the penis with the urethra inside, then also the scrotum or the scrotal sac that houses the testis, the epididymis. Then the internal genital organs includes the vas deferens, which extends to join the seminal vesicles, forming the ejaculatory ducts, then also the prostate. We'll start with the penis. The penis is one of the most important parts of the male external genitalia. It has two paired corpora cavernosa, as shown, which are joined by an incomplete septa distally. Then proximally, they are attached by the crura to the infrapubic arch. Then also the corpus spongiosum that surrounds the urethra expands distally as the glans penis, then proximally as the bulb. When you see a cross-section through the penis, you see that the penis has several coverings, from the skin to the superficial dartos fascia, a deep box fascia, then the layer of the tunica albuginea, which surrounds the corpora cavernosa and the corpus spongiosum. In terms of blood supply, the penis is supplied mainly by vessels coming off from the internal pudendal artery. The internal pudendal artery divides into the dorsal artery of the penis, as shown. Then also the deep artery of the penis, which continues as a cavernosal artery, supplying the substance of the corpora cavernosa. Then the bulbar urethral artery, which comes off, enters the bulb, supplies the corpora spongiosum, the urethra. Then also anastomosis with some branches from the dorsal artery of the penis at the distal aspect of the penis, giving a dual blood supply. In terms of venous drainage, is drained by two systems: the superficial venous system that is external to the box fascia and drains the skin and the dartos fascia. Then the deep venous system, which is deep to the box fascia and drains the substance of the penis. Then the lymphatic drainage is essentially to the inguinal group of nodes, the penile skin, the shaft, and the glans penis. Then in terms of the nervous supply, it's supplied mainly by the pudendal nerve, that gives off the sensory innervation through the dorsal nerve of the penis. Then also it has a somatic innervation that comes when the S3, S1, S5 spinal nerves joins the pudendal nerve. And also it has an autonomic supply, which gives rise to the sympathetic that's involved in ejaculation and the parasympathetic innervation involved in erection that comes from the pelvic plexus. Then it has a small supply from the perineal nerve. This is an image showing what we just described. Then the next structure to be considered is the urethra, which is a tube that is contained within the vascular corpus spongiosum and the glans penis. It has two main parts divided by the perineal membrane, the anterior urethra and the posterior urethra. It's about 20 to 25 cm in length in the male, 8 to 9 millimeter in diameter. In terms of blood supply, it has an antegrade supply from the bulbar urethral artery and a retrograde supply from the dorsal artery via its circumferential branches. Then the venous drainage is essentially to the pudendal veins. Lymphatic drainage is to the internal iliac group of nodes and the common iliac nodes. The next organ here is the scrotum, which is a sac-like structure that houses the testes, as can be seen in this image. It is divided by a septum into two hemiscrota. Then in terms of the covering, it has the skin, then the superficial dartos layer, the external spermatic fascia, the cremaster muscle and fascia, the internal spermatic fascia, then also the tunica vaginalis. Then the testis is very important as a part of the external genitalia. These are paired organs within the scrotum, has a length of 4 to 5 cm. Then it has a volume of about 15 to 20 mil. In 85% of men, the right tends to hang lower than the left. It's surrounded by a tough capsule, which from external to internal are made up of the visceral tunica vaginalis, the tunica albuginea, the tunica vasculosa. Then the epididymis attaches posteriorly. Then the cross-section through the testis shows that the tunica albuginea are the mediastinum testis invaginates, forming multiple septae that divides the testis into about 200 to 300 lobules, as shown. Each of these lobules contains semiferous tubules, one or more of these semiferous tubules, that has a convoluted part and a straight part. The straight part of the semiferous tubule eventually ramifies, forming a network known as the rated testis, as shown. Then from this rated testis, certain connections called the efferent ductus arises and connects to the head of the epididymis, known as the caput epididymis, which continues as the body, the tail, then the vas deferens. The blood supply of the testis essentially comes from three different parts. It comes from the abdominal aorta, which gives off the testicular artery, then also comes off from the superior vesical artery, which continues as the artery to the vas deferens. Then the inferior epigastric artery continues as the artery to the cremasteric muscle and fascia. And this all anastomose to give a real blood supply to the testis. In terms of venous drainage, the testis is also drained by numerous veins, all forming a network known as the papilliform plexus of veins, which is shown in this image. And this is very important in testicular function, as it tends to keep the temperature of the testis lower than the core body temperature to allow for spermatogenesis. Then let's go to the epididymis. The epididymis is also a part of the male external genitalia, tightly called tubules, which are comma shaped, attached to the posterolateral wall of the testis, about 3 to 4 meters in length when stretched. It has the body, it has the head, the body, and the tail. It's encapsulated within the tunica vaginalis. It continues as a vas deferens at the tail. This is an image showing the epididymis. Then let's go to the vas deferens. It's a tubular structure and extends from the caudal epididymis to the ejaculatory duct. It joins with the seminal vesicles to form the ejaculatory duct, about 30 to 35 cm in length, then about 0.2 to 0.7 millimeter in entire diameter, and 1.5 to 2.7 mm outer diameter. It has a convoluted part, about 2 to 3 cm, and a straight portion. And for convenience of discussion, there are 5 parts of the vas deferens, and this is shown in the image. Now, the seminal vesicles and ejaculatory duct. This is part of the internal genital of the male. These are paired viscous organs that are positioned posterior to the bladder and prostate. Typically measures 5 to 7 cm in length and 15 cm when stretched out, and 1.5 cm in width. It has a capacity of 3 to 4 mil. The ejaculatory duct is divided into 3 distinct anatomic regions: the extraprostatic region, the intraprostatic, and the distal portion, which joins at the very momentum of the prostate. This is an image showing this. These are the seminal vesicles, paired structures that joins the vas deferens to form the ejaculatory duct.
Mindful of our time.
Yes, sir.
Go ahead.
The
Try to
prostate.
summarize.
The prostate is an organ that is about 18 to 20 grams in size, aborts the bladder base and apex is distal, has some distinct anatomic regions as shown, the peripheral zone, the central zone, and the transition zone, as well as the fibromuscular stroma zone. The arterial supply of the prostate comes from three different aspects. The main is the inferior vesical artery, others are the middle rectal and internal pudendal artery. Now let's look at the reproductive physiology. This talks about the reproductive processes and complex functioning of the reproductive tracts. The hypothalamus pituitary gonadal axis is the most important part of this male reproductive physiology. It regulates four physiologic processes, and communications are mediated by two main hormones, which includes the peptide hormone and the steroid hormones. Negative feedback activity within this system tends to ensure homeostasis is maintained. However, as the man ages, certain changes occurs in this axis, which includes lowering of the testosterone level, blunted axis feedback, and irregular hormone pulsatility. The hypothalamus supplies the gonadotropin-releasing hormone, which is the main reproductive hormone. It tends to act on the pituitary, the anterior pituitary gland, which produces luteinizing hormone and follicle-stimulating hormone. These hormones are very important in the production of testosterone as well as in spermatogenesis. The pituitary gland has two parts, the anterior pituitary and the posterior pituitary. The anterior pituitary is the main site where the hypothalamus acts on, and the luteinizing hormone is produced and it acts on the Leydig cells to produce testosterone, while the follicle-stimulating hormone, when produced, tends to stimulate spermatogenesis. Prolactin is another hormone produced by the anterior pituitary. The role is less clear. However, high levels of prolactin tends to inhibit the pulsatility of gonadotropin-releasing hormones. Hence, it's very important in assaying for this when evaluating for infertility. Other hormones are also important in male reproduction. The testis has two main functions in the male. These are the endocrine function that produces the testosterone, and the exocrine function that involve in spermatogenesis. The epididymis is an important aspect of the male reproductive tract, which has several roles, one of which is the fact that it's involved in sperm transport, sperm storage, sperm maturation, and the process of sperm passing through the epididymis tends to allow for activation of the sperm so that it can fertilize the ova. Then the vas deferens also very important in sperm transport, as about 130 million ejaculated sperm is reserved in the vas deferens. It's also involved in absorption and secretory processes. The seminal vesicle and ejaculatory ducts. The seminal vesicle secretes about 80% of the seminal fluid. It produces a chemical substance known as seminogenin, which is involved in coagulation of sperm. It also tends to maintain alkaline pH of semen.
Hey, Dr. Magnus, you should try to summarize things. You've taken 3 minutes more. Go ahead. Try to summarize, please.
Thank you, sir. It also provides fructose, which nourishes the sperm cells and provides anti-oxidative properties. Spermatozoa, this is the male gamete, which is involved in fertilizing the ova. It has 3 parts, the head, the neck, and the tail. The overall build of the sperm is to ensure that the female ova is fertilized. This is an image showing the spermatozoa. In conclusion, a good understanding of the male reproductive anatomy and physiology is key for the management of male infertility. Thank you.
Thank you very much. I seem to have been hurrying you up, but we took about 3 to 4 minutes extra. Thank you. Please
for sharing your slide.
Yeah,
all
I
right.
think the next person I'll call will be Nabugu. So thank you for bringing our memory back to anatomy and physiology of the male reproductive system, Dr. Magnus. Dr. Nabugu, we'll listen to you talk to us about the etiology of male infertility. Okay, your time starts now. 10 minutes, please. Try to make it in 10 minutes.
All right. Thank you very much. I join others in welcoming us all. My bit is to tell us in a couple of minutes, highlight factors that come into play when we consider etiology. in male factor infertility. You need to understand that you don't expect everyone to understand the enormity of the problem, especially if the person had never walked along that same path. So this is difficult in trying to take care of this condition. We must understand what it is all about. And then by doing that, we need to understand the causes of this problem. With a good understanding that already have been laid before us, the anatomy and the physiology of the male reproductive pathway, it will be a lot easier to understand points where defects can occur in terms of understanding the etiology. However, I must say very early that a lot is yet to be clarified with respect to the issue of conception and no conception between any couple. In a number of cases, you may be unable to identify a cause. There are a number of reasons why this could happen. One reason is that you don't have enough, you have not been able to feel the cause because somebody along the line, along the way, has given a wrong information, which leads to a false negative declaration that there is no cause, that somewhere there is really a cause that has been missed, or that we have limited capacity to assess deeply to be able to say that this is really what the cause is. In some other situations, there really may not be a cause. And in this situation, when you're declaring that everything is negative, it may really be a true negative declaration. Now, when there are causes or when there is a cause, some of these could be, one, I want to put it in a way that for our residents who are listening, it may be easier to follow and not forget something along the line. Take it that the spermatozoa is a seed being planted in the soil where it needs to do some things, germinate and then grow. So if there is impairment in the capacity to produce this seed, there's likely going to be male factor infertility. This impairment could be a primary testicular failure, which we could see from some of these conditions I have listed here. Genetic conditions, a typical example is the Klinefelter syndrome, where there are a number of acquired conditions that will lead to primary testicular failure, some of which we see commonly will be neglected undescended testes, absence of testes for whatever reason, poorly managed torsion of the spermatic cord, and a whole lot of others. Viral orchitis, a typical one is the mumps orchitis, radiation injuries, chemotherapy injuries, and then one thing that we also see very commonly, the varicocele. These will lead to some form of primary injury to the testes and will lead to primary testicular failure. The other aspect of impaired capacity to produce the needed seed will be seen in form of secondary testicular failure. Typically, is where we'll have the hormonal imbalances, low testosterone levels, high prolactin levels, and so on, that will result in impaired capacity. Low follicle stimulating hormone, low luteinizing hormone levels that will result in impaired capacity of the testes to generate the needed seed. Okay, in our environment, a study from Onisha by Obiechin et al., that's a long time ago, though, in 1994, noticed that in absence of sperm within the semen contributed to about 62% of the number of patients they saw, 628, within a space of 5 years. And then oligospermia, low counts, contributed for about 31% of this. There are other seminal parameters that can be identified, telling us that the quality of the seed is defective. I think the person that will take investigations will highlight on all this. Now, The second aspect is impaired delivery of the seed. Okay, this can also come in two levels: structural defects in the internal stroke external genitalia, and then functional defects in the external genitalia. Now let's take the structural defects. Situations where we'll have epididymal obstruction as a result of, and some could be congenital, sometimes acquired epididymitis, post-epididymitis, or granulomatous infections could lead to some obstruction of the epididymis, or vessel obstruction from surgeries in the past, groin surgeries, and so on, or in situations where there is retrograde ejaculation, which we can see post-prostatectomy, or in some people, there may not have been any intervention, but it becomes a problem. Urethral stricture is a structural defect that can lead to impaired delivery of the semen into the vaginal introitus. Meatal stenosis and phimosis, and then hypospadias. Many of us may have encountered in the elderly men who actually grew up with hypospadias and didn't know it could be a reason why they were unable to achieve pregnancy. Now, in the functional aspect of it, defects in function of the external genitalia, the penis in particular, erectile dysfunction is a common condition that we can see amongst people who are unable to achieve pregnancy. Some of these may be because of other issues that caused inability to conceive, with the erectile dysfunction being a secondary issue, or in some other situations is the primary reason why there is inability to conceive. And ejaculation is also known as a cause. Now, it's not common, but you can see this once in a while, where the man is actually, or the couple is actually ignorant of when exactly to have intercourse, coitus, that may lead to cysts. This becomes a cause. So also try to think about this when we are exploring the cause of this condition. Now, in other situations, the seed is being transported in an abnormal medium. The seminal fluid is a good medium for transporting of spermatozoa, but in some situations, content of that seminal fluid becomes defective, and that becomes a problem. When the fructose level is abnormally low, or when there's problem with the type of PSA, prostate-specific antigen, within this seminal fluid, that can affect reproduction. Now, so much is unknown currently in this area, but research is going on very well in this area. Another aspect is where the soil in the female, soil in quotes, is hostile. I don't know whether we will call this a female factor or a male factor, but it is known that some spermatozoa stimulate antigenic response from the female, a particular female, and that may not happen in another female. And such situations, it may not really be the female that's the problem. It's actually the male that brings in an antigen into the female. This can be a cause of infertility. Again, this is an area that we still have a lot of research going on to see how much this area contributes to the issue of infertility. Sometimes it has been documented that reactive oxygen species are required at physiologic level within the female genital tract to help the spermatozoa function when it has been introduced into the female genital tract. When these reactive oxygen species are in abnormal levels, that can affect conception. Going further, the spermatozoa itself may be defective in ability to go through capacitation or chromosome reactions or zonal polycidal penetrations. These are issues that by the time you're exploring, you're taking information or evaluating the male, you're unable to see why he's unable to father a child. But it may just be because something is wrong in the functional capacity of the spermatozoa when delivered in the vicinity of the female environment. Again, research in this area has not, we don't have so much information in this area to talk confidently on how exactly to take care of this particular side of the problem. Okay, so
time again, sir.
Yes, I'm done. With good knowledge of these points, it could be easily to understand that evaluation of these men should be comprehensive and focused. Thank you very much.
Yeah, thank you very much, Dr. Nabugu. Yeah, you've tried to keep within the time, just a few seconds above. Of course, taking us through the etiology of male infertility. Thank you. Our next speaker is Professor Linus Ekeke. Okeke, not Ekeke this time around. You'll be taking us through clinical evaluation of the infertile male. Thank you very much, sir. The time starts now.
Thank you. Good evening, everybody. Your system is preventing me from, okay.
No, go ahead.
I'm fine.
We're saying, so.
So male factor infertility is a very serious social stigma. My own is to present the clinical evaluation, that's the history and the physical findings. In the history, we'll start right from the beginning, the developmental history. A history of mumps and any other viral illness. Sometimes the patient wasn't told whether they had any of these problems. So we may have to rely on a second visit if they can substantiate from the parents if they're still alive and if they still remember. A history of scrotal injuries when they were young, testicular torsion, management for testicular maldescent. For histories concerning puberty, most of them are aware. And so they were able to answer about when puberty came on board, and then sexual development. Then history of scrotal pains. Pains suggestive of torsion. The nature of the pain, acute onset, scrotal swelling, and how it was managed. Some pains will suggest varicocele. These pains typically come on later on in the day. They are worst before bedtime. And usually the patients will promise themselves that they will see the doctor the next day. By the time they sleep overnight, the venous drainage would have emptied all the impurities, the pains would have disappeared, would have totally forgotten to go about their normal business. It's only to promise again the next night that they will see the doctor. So that's the typical pain of varicocele. Then we ask about lifestyle factors, environmental and occupational factors, like what kind of underwears they use. Is this cotton or nylon? Nylons tend to conserve heat for them and increase the external temperature around the scrotum, tending to raise the intratesticular temperature. And exposure of genitals to undue heat. Those days it was people who worked in steam engines. These days, people who work in bakeries are exposed to a lot of heat, especially the local bakeries. And cell phone usage, drugs and steroids, hot tubs, which we don't have much of, smoking and alcohol, and obesity. Then we also ask about their medical history, diabetes, hypertension, respiratory, liver, neurological diseases, episodes of high fevers in the past, which may have baked the testicles, urinary tract infection, sexually transmitted diseases, and any other medications they might be on and the duration of usage. And then surgical history of vasectomies. We've seen patients, especially the Caucasians who may have had vasectomy, marriage ends, they remarry, and then don't remember that they had vasectomies before, and then they present for infertility. Testicular surgeries, inguinal surgeries like inguinal heniographies or heniotomies when they were much younger that may have tampered with the integrity of the vas deferens. Sympathectomies in the past that might make it difficult for them to ejaculate. Prostatectomy that might lead to retrograde ejaculation. Bladder neck surgeries, same problem. Urethral strictures, hypospadias, epispadias repair. And some families have a family history of infertility. They will tell you their parents were married for like 10 years before they had their first child. History of recurrent pregnancy losses, which may be due to unhealthy spermatozoa, congenital sperm defects, history of cryptorchidism, metabolic syndromes, sorry about the spelling of syndrome, and endocrine disorders. Then we get the history of their marriage. How long have they been married and how long have they been unable to achieve fertility? History of past conceptions with the present or previous partner, which will help us to categorize whether it's primary or secondary infertility, and previous investigations they may have had and treatment they have had for this condition. Sexual history is actually important. We want to know the frequency of sexual intercourse. These days, we have adults who grew up in the age of HIV who learned how to effectively use the condom. And then they get married and they're still using the condom. So there's no way they can get pregnant. And there are those whose definition of sexual intercourse is penis in the anus. And so they can't achieve pregnancy. So we have to find out whether it is penis inside vaginal intercourse. Some may not have libido, erectile dysfunction, problems with ejaculation, and some because of use of lubricants. So we go on to examining the patient. The examination actually starts when the patient is walking into your clinic. If he's so tall, he has to bend down so that he doesn't hit his head on the door frame. Something might be wrong. There might be evidence of delayed or absent puberty, like in Kallmann syndrome. Very tall, with slender, long finger, like in Klinefelter syndrome. Or you might actually perceive a nasal voice in people that have Young syndrome because they have persistent sinusitis and sinopulmonary infections. We examine their breast for galacturia, which might indicate that they have hyperprolactinemia. And then we examine the abdomen, typically for presence of scars of previous inguinoscrotal surgeries. And then the genitalia, penis, urethra, testicular size, and consistency. For testicular size, we use the orchidometer, the Prada orchidometer, or the one we described from UCH from putting in predetermined quantities of water in fingers of gloves. If you don't have Prada orchidometer. One of my examples typically is to say that if, for instance, somebody tells you he assembles Boeing 747 in his bedroom, it's not likely to be correct because that bedroom cannot be adequate for the work needed, the size of the aircraft. So sometimes the testicles are too small to be consistent with fertility. Then we examine the vas. Beaded vas might mean that the vas is actually obstructed from previous recurrent infections. And then we look out for varicocele for their presence and their grade. That's all I have for you. The next speaker, Dr. Mufta Obioku, will be discussing the investigations. Thank you very much.
Yeah, thank you very much, Prof, for keeping to time and sparing us some time as usual. Dr. Bioku, investigations of the infertile male. People can begin to send their comments to the chat room.
Thank you very much, the moderators, our teachers, distinguished participants. My bit is to discuss the investigations of male infertility. And I'm going to go starting with the goals of investigation. So we are interested in identifying the correctable causes such that the couple can conceive through intercourse and with the least amount of technology. So we're also interested in identifying the reversible condition that may not be amenable to treatment with assisted reproductive technology. So we also intend to detect irreversible condition in which the man's sperms are not obtainable. So in which case the couple may have to consider adoption or donated sperm. So the goal is also to detect medical diseases that may be associated with infertility that require treatment. So it's also important to identify specific genetic causes of infertility that may be transmitted to and impact the offspring. The investigations of choice are grouped mainly into three: the laboratory, imaging, and testicular biopsy. So semen evaluation is the primary source of information on sperm production and reproductive tract patency. So the WHO 2010 have identified the new minimum criteria for normal semen quality. So count and motility, which appear to correlate with fertility rate. And it is important to ensure that the quality control is ensured for a meaningful interpretation. So pre-analysis, collection protocols will be strictly adhered to. According to the same WHO manual, a minimum of 2 days to a maximum of 7 days of sexual abstinence should be ensured. So the semen is collected either by masturbation at the laboratory private room, and if that is not possible, using condom that does not contain spermatocyte. So but the specimens will be delivered to the laboratory within 1 hour. So at least 2 samples should be collected about 2 weeks apart, but no more than 3 months. We can use the manual assessment, or we can use computer assisted sperm analysis. So the manual assessment is laborious and sometimes complex. So, but that is what is available in most centers, and that is involve the use of a phase contrast microscope. So in contrast to the computer-aided microscope that is semi-automated and has high precision and quality assessment of semen kinetics. But the advantage is that it is expensive. So in our center, we still use this sperm quality analyzer, so which after instilling the specimen will give us this result. So it has the WHO parameters as part of the result given us. So the standard semen quality seminal fluid examination includes microscopic and microscopic examination. In the microscopy, we are interested in liquefaction. So the liquefaction usually occurs within 30 minutes of ejaculation. So, but if it's more than 60 minutes, so it is said to be delayed. Viscosity is also examined. Semen volume is examined. I'll give the WHO lower reference rate soon, and also as well as the pH. The microscopy should assess the agglutination, that's the stickiness of the spermatozoa to each other. And that may be by head to head, tail to tail, and sometimes mixed agglutination. So concentrations will be examined as well as the total count, the motility, that's the percentage of the motion of the sperm. Then the morphology, the round cell as well as the leukocyte. So this is the current WHO lower reference range, where the volume should not be less than 1.5 ml. The pH should be 7.2. Concentration should not be less than 15
million per male, while the total ejaculate, that's a multiplication of concentration and this volume, should be 39 million per ejaculate. So the motility, the progressive motility and non-progressive motility should be up to 40%. So whereas the progressive motility alone will be up to 32%. So the vitality of the sperm should be 58%. By Screen's criteria, the normal form, the morphology, should not be less than 4%. So this is the reference range evolution over time from 1980 up to year 2010. So this is the current one that I just discussed. So after the semen analysis, we should be able to, combine with history and examination, we should be able to make this post-diagnosis, whether there is absence or sperm hypovolemia, or whether there is exospermia, oligospermia, actinospermia, teratospermia, or a combination of this defect, or maybe it is normal, but yet the patient is still infertile. So that will now give us the direction of the next line of investigation. Absent of sperm hypovolemia, we suggest that we need to rule out incomplete collection or short abstinence period, because that will reduce the sperm volume. So we also need to be sure that we also need to do post-ejaculatory urinalysis. So if that is positive, that means they are retrograde ejaculation. But if it's negative, we need to go and rule out obstruction by transrectal ultrasound. So if we have exospermia, we need to determine whether it is obstructive or non-obstructive. So for by using ultrasound, if the ultrasound suggests there is bilateral atrophy, then the hormone is acid. So the same thing, if there is a absence of fat, then we need to follow this algorithm. So in the case of abnormal motility, so we need to determine whether there is an anti-sperm antibody, so that may cause a hemorrhagic disease in the patient. So, and we also need to exclude a varicocele or systemic illness, as mentioned by the earlier speaker, as well as infections. So endocrine test is important, even though it is said to account for less than 3% of infertile men, and it is indicated if there's abnormal history and physical examination, and also the sperm concentration that is less than 10 million per male. So the important hormones that are tested are the serum, testosterone, luteinizing hormone and follicle stimulating hormone, prolactin. Sometimes we test estradiol, thyroid function test, and 17-hydroxyprogesterone in the case of congenital adrenal hypoplasia. Morning testosterone is important, and there may be need to repeat it if the value is borderline. So the same thing with LH and FSH. So if there is high follicle stimulating hormone and LH, you should be thinking of primary hypogonadism. Prolactin is also important, especially if it is more than twice the normal value, and there is impaired visual field and severe headache may be associated. So inhibin of recent has been said to even be more sensitive than the follicle stimulating hormone, particularly inhibin B that is produced by the male. So with the interpretation of the hormone profile is as shown here. If there is elevated FSH and LH, but with low testosterone, we'll be thinking of testicular failure. But if all the hormones are low, so we may be dealing with hypogonadotropic hypogonadism. So it may be normal, all the hormone may be normal in the case of obstructive exospermia, or if the patient is normal, but still has infertility. The genetics testing is not routinely done in most cases, but the current American Urological Association best practice recommends that for all male patients with exospermia that is caused by spermatic dysfunction, and also if there is severe oligospermia, so to detect some of the genetic abnormalities like Klinefelter syndrome, Kama syndrome, Young syndrome, but it is not routinely done in this environment. and the test is quite expensive. We can also assay Y chromosome microdeletion test. So that is recommended, especially if we want to do surgical sperm extraction for IVF. So the other less commonly genomic testing include gene mutation testing for cystic fibrosis and also genomic sequence assessment. The imaging is key in the investigation of male infertility. So to identify partial or complete obstruction of the duct. So fasciography, for instance, is done traditionally to evaluate the vas and ejaculative duct. So, but it's best performed in conjunction with reconstructive surgery so that there won't be fibrosis by the time you come back to do that. So in that case, the vas is punctured at the level of scrotum most time and injected with contrast. So venography.
Our time again, thank you.
Can also be done to guide embolization in varicose cell. So this is the scrotal ultrasound to detect the testicular volume. The normal is 15 to 20 as said by the previous speaker. It can also detect varicose cell. So if the pampillon plexus is the diameter is more than 3 mm. So it's also had the capacity, as well with the aid of color Doppler ultrasound, to detect the direction of flow of the vessels. So transrectal imaging ultrasound is also key. It assesses the seminal vesicle as well as vas and the prostate. If there's a midline cyst, so it is destructive. And if the AP diameter of the seminal vesicle is more than 1.5 centimeter, it suggests obstruction of seminal vesicle. So this is the cranial MRI. It's indicated if more than twice. So testicular biopsy can be done mainly for diagnostic to differentiate between obstructive exospermia and non-obstructive exospermia. And these findings may be so, and it's also be used therapeutically to harvest sperm for IVF. So testicular biopsy in the current practice, however, is being discouraged and is said to be unnecessary to differentiate between obstructive exospermia and non-obstructive exospermia. That can be detected only with FSH value and also the ultrasound. So in 96% of men with obstructive exospermia, where follicle centimeter a month is normal, and the testis long axis is greater than 4.6 centimeter. So, and in non-obstructive exospermia, it's been found out that 89% of men have a higher or elevated FSH, and the long axis less than 4.6 centimeter. So in conclusion, after thorough history and physical examination, all infertile men should have at least 2 or 3 semen analyses. I mean, with this, we can have a working diagnosis, as earlier said. So that will now guide us for more specific testing, so that may then be performed to place the patient into an etiologic category. These are my references. Thank you very much.
Thank you very much, Dr. Bioku, for this overview on investigations of the infertile male. Professor Ahmed, next with treatment, which includes both medical, surgical, and I don't know if there's traditional. You can take all. He's muted.
I'm looking for him.
Ahmed is muted.
Okay.
Thank you very much. I was speaking to myself, I'm sorry. So I'll just take us through the treatment of infertility, and I want to thank all the presenters who have done a great job so far, and my teachers as well who are here. So I'm greatly honored. Looking at the treatment, there are general measures which can apply to most patients with infertility. And go back. And these include lifestyle modification, coital therapy, like time coitus, or at least every other day, and to stop drugs that affect spermatogenesis if such patients are on them. Evaluation of the female partner is also important to go on concurrently with the management of the male. For specific conditions like the idiopathic male infertility or non-obstructive azoospermia and the oligoasteroteratozoospermia syndrome, some of the things that could be done include the use of hypogonadotrophic. I mean, and then of course, beside the various conditions that warrant medical treatments, the idiopathic infertility, the hypogonadotrophic hypogonadism, which could be, of course, excluding the primary. Primary does not, I'm sorry for that error. The hypogonadotrophic hypogonadism should be specific for the secondary hypogonadism. Then you have the hyperprolactinemia, hypothyroidism, and congenital adrenal hyperplasia. So we'll just go through some of them quickly. For those with idiopathic male infertility, non-obstructive azoospermia, oligoasteroteratozoospermia, also known as the OATS syndrome, the exact cause or management of these cases, and there are no clear specific mode of treatment of such patients. And so a lot of the treatment modalities includes empirical treatment, and this includes lifestyle modification, like weight loss, and that improves obesity-related secondary hypogonadism because of the peripheral aromatization of androgens to estrogen. Then physical activity, exercise should be encouraged. Smoking cessation, reduced alcohol consumption are all important in improving sperm quality. Antioxidant therapy, not proven, but a lot of agents are used around the country. There are marketers of these agents, but there are no clear-cut evidence based on scientific research to prove their effectiveness. However, they are still in use, and probably they may have some role. Then aromatase inhibitors like testosterone and non-steroidal forms with the anastrozole could also be used to stimulate gonadotropin production. Selective estrogen receptor modulators like clomiphene could also be used in these settings where there are no clear-cut causes of infertility. For primary hypogonadism, in this case, of course, the gonadotropins are high, follicle-stimulating hormone and luteinizing hormone are high because the primary disease is in the testis, and as such, testosterone production is reduced genesis. And that way you have
Can we mute AE?
High levels of gonadotropins. In these settings, there is no substantial evidence to support gonadotropin therapy in patients with primary hypogonadism. And of course, with the presence of primary classical testicular failure, gonadotropins are unlikely to work in such patients. There's also no evidence to support the use of other hormonal treatments, which includes the selective estrogen receptor modulators but in these patients, the assisted reproduction offers the best chance for patients who have primary hypogonadism. Okay, for secondary hypogonadism, it is classified as either prepubertal or pubertal. If the onset of hypogonadism predates puberty, and such patients usually will present with some degree of, or significant degree of hypogonadism or poor virilization. Hormonal therapy is mandatory in this group of patients using gonadotropins, including HCG, FSH, and gonadotropin-releasing hormone analogs. The human chorionic gonadotropin is given twice weekly in this group of patients, and starting with a dose of 1,000 international unit twice weekly, and this can be escalated by monitoring the testosterone level 2 weekly until the normal level is achieved. Those escalation can reach up to 5,000 international units 2 to 3 times a week until testosterone levels, normal testosterone levels are achieved. Once this level of testosterone, normal levels are achieved, then it is advised to also commence follicle stimulating hormone of about 175 to 150 internationally 3 times weekly, subcutaneously, and this should be commenced when normal testosterone levels are reached. The higher doses of 150 international unit 3 times weekly is needed to be successful, particularly in men who have very small testes, less than 4 mils. For those with secondary hypogonadism, in which case they achieved normal puberty. However, beyond puberty, then hypogonadism became evident. And there are infertile patients like that whose hypogonadism became evident after puberty. So such males have almost normal sized testes and have relatively good level of virilization. And only the hypogonadism only begin to manifest later in their life, and that can affect, and that ultimately affects their fertility. And what is recommended here is HCG alone, which is sufficient to stimulate spermatogenesis in this group of patients. The doses of subcutaneous HCG required may be lower than in those in prepubertal hypogonadism. And the starting dose could be as low as 250 international units twice weekly. And then the dose may be increased up to 2,000 international units. As compared to, you can see a much lower dose required compared to the up to 5,000 international units required in those with the prepubertal hypogonadism. For other medical therapies for other conditions, including hyperprolactinemia, the agents that could be used include dopamine agonists like bromocriptine, cabergoline, and others. Those with hypothyroidism could be treated with L-thyroxine, and then patients with congenital adrenal hyperplasia will require corticosteroid replacement. A key thing to note here is that even among patients with hypogonadism for any reason, for who are infertile, do not use testosterone therapy in the treatment of male infertility, because it is substantially inhibit the gonadotropin release, FSH and LH, and that will by a negative feedback effect, and that will ultimately reduce or impair spermatogenesis. But testosterone replacement could be used in patients with hypogonadism who are not desirous of or considering parenthood. So it's not an absolute contraindication. It depends on what the patient desires. For surgical management of male infertility, these are some of the surgical procedures, some of which have been mentioned by Biogo. They are both therapeutic as well as investigative. The testicular biopsy, in which sperm could be retrieved, spermatozoa could be retrieved and cryopreserved for assisted reproduction. Vasography usually is done in combination at the time of reconstruction. So it's both diagnostic and at the same time therapeutic, in which when it is combined with reconstructive procedures. Then vasovasostomy, vasoepidermostomy, transurethral resection of the ejaculatory duct, electroejaculation, sperm retrieval techniques, varicocelectomy.
I'm factor again.
So I'll just go quickly beyond this, since these have already been mentioned, and go to the obstructive exospermia. The obstructive exospermia accounts for about 20 to 40% of patients with infertility in some series. And then they have a normal FSH, normal size testis and epididymium, but with epididymal enlargement. The vas difference may be absent bilaterally or unilaterally. The obstruction to the could be at the intratesticular level, which accounts for 15%, and extratesticular, which is the commonest type. Epididymal obstructions are the commonest, accounting for 30 to 67%. And of course, vas difference obstruction, which is commonly acquired post-vasectomy. And then the ejaculatory duct obstruction, which is often congenital or acquired. The vasography, these are just the indications, absolute and relative indications for vasography. Vasography is only required when it's going to be done at the time of reconstruction, as earlier said. And these are just images of vasography, some of which we did. For microsurgical vasoepidermostomy, vasovasostomy and vasoepidermostomy, this is a technique. The microdot technique is a commonly used technique presently for vasovasostomy. And of course, for vasoepidermostomy, the intercepted enterocyte anastomosis of the vas to the epididymal tubules is a preferred technique and has successfully compared to others. This is one of those we did in Abbots. Then for ejaculatory duct obstruction, the treatment includes transurethral resection of the ejaculatory duct in cases of obstruction due to midline intraprostatic cyst. Incision, unroofing or deroofing or aspiration of the cyst might suffice in those group of patients. For varicocelectomy, which accounts for a significant number of patients with infertility, accounting for 50% of in general population and 35% of infertility, primary infertility, and then 75 to 81% among males with secondary infertility. It results in progressive decline in testicular function. Varicocelectomy is the most commonly performed operation for male infertility. And these are some of the images of the varicocele. There are different methods of varicocelectomy, which are compared here between the inguinal approach, the open retroperitoneal approach, and then the microsurgical inguinal or subinguinal approaches. The retroperitoneal approach has the highest recurrence and persistence rate up to 15 to 29%, while the microsurgical technique, transinguinal technique, has the least recurrence rate of 0.4. But the one commonly done in this in our country or around the country usually is open a transinguinal approach. But I know a few people that do the retroperitoneal approach, and and then of course the laparoscopic as well. The minimally invasive modes of treatment of varicocele include antegrade sclerotherapy, retrograde sclerotherapy, and retrograde embolization. Comparable recurrence rates with some of the open methods, but however, they also have a few complications as well, as listed here. For the sperm retrieval techniques, I'm sure our guest presenter is going to talk about that on the assisted reproductive techniques, so I will not spend time on that. Thank you very much for listening.
Well, thank you very much. I know you had the last topic which was so large for the time you had, but that was good. We will now listen to Dr. Sunday Onu, the OBGYN amongst us. First, he will give us a talk on ART, assisted reproductive techniques, and then he will take a second topic, which is ethical issues on gonad donation, or would I say egg or sperm donation. So Dr. Onu, please, let's have your first talk, and then you will take the second one.
Yeah, okay, thank you very much. My able chair, it's a great privilege to be among strong people that work above the waters or inside the waters, where we work in the 1% area. And I must say that I have great friends and collaborators among, work closely with two urologists in town, that's Chiva and Kalina, because of the nature of what we do. There's a cross reaction. I'm going to be brief because the topic before me is so large, but I'm time conscious, and I would think I'll be able to do justice to the time. Yeah. By way of introduction, assisted reproductive technology includes any fertility treatment in which either egg or embryo is handled. Either egg or embryo. handling of sperm does not qualify anything to be classed as assisted reproductive technology. The reason is, sperm can do the job by itself, and it's easier for sperm to be obtained than getting egg or handling embryos. ART has actually revolutionized the management of infertility because people who hitherto would have been classed barren, by virtue of ART have begin to smile, as it were. It took unrelenting effort of the pioneers of ART to achieve a breakthrough. To interest you to know that the first IVF pregnancy, the first recorded pregnancy and delivery was achieved after about 200 failures. So it's not just as easy as it is. Tenacity. And since the birth of the first baby, a lot and host of babies have been delivered by ART. The indications of ART, I will not bore us because, female factor was the primary reason for ART along the line because of limitations of what ART provides. The male factor came in heavily. And the male factors, which is usually very easy to diagnose that there's a male factor. It's either the sperm count is very low or the function is very poor. That's a diagnosis. And what else do you need is treatment, which earlier speakers have outlined. But it comes to a point that all the conservative management or medical management will come to a stop and we'll have to move higher. That's where ART comes. What male factors will make us consider ART? Yeah, when there's severe oligospermia, or the Oates syndrome, or functional problem with the sperm, or we have obstructive exospermia, even some cases of non-obstructive exospermia, and some other cases of retrograde ejaculation, where we have to get sperm from the urine and use for the purpose of ART. Yeah, we'll go just a little bit about the procedural steps in ART. The initial step, actually, we have to evaluate, select patient, because if patient selection is poor or is bad, you are doomed to have a failure. Then counseling and consenting is very important because a lot of times people tend not to know what is being done for them. Or they just come take injections, do this and go. It is very, very important to counsel the patient and obtain a written consent. And counseling is also part of, giving them the possible outcome, because some people will come and go and borrow their life saving, go and borrow their village, go and borrow everything, coming to do ART with the mindset that, yes, this thing is 100%. IVF is not 100%, ART is not 100%, so they must know. And so other people will come with the mindset that, oh, it's twins I want or a triplet I want, that's why I'm coming to do IVF. So, which is not actually the situation. Yeah, the next stage will be, the treatment proper. After, proper evaluation, do investigations, rule out anything that might affect the outcome of the IVF itself. Take it out before you move forward. Control ovarian hyperstimulation, because in IVF, we want multiple eggs as against the single egg that nature provides, or in IUI, where you want, okay, maybe 1, 2, or 3 eggs information. The reason for multiple egg production in IVF, why we do that is because it is going to, egg is going to be handled. It's not all eggs that you get that actually will be treatable. It's not all eggs that you treat will be able to fertilize. It's not all that fertilize will be able to divide and grow. So with that at the back of the mind, because the aim of the whole thing is for you to have a good embryo to transfer and eventually achieve pregnancy and live birth. So it's better to have choices to make than nothing to use. At the same time, we're also mindful of having excessive egg production, because that will lead to some severe complications like the ovarian hyperstimulation syndrome. that comes along with IVF. There are various protocols that are used for ovarian hyperstimulation. I will not bore us, but mostly the major ones that are used are the long protocol and the short protocol, particularly the short antagonist protocol, which is, what is taking over the world now in terms of protocol being used. There are various other protocols. And after the hyperstimulation, the next stage is the ovulatory trigger. You want to trigger ovulation by giving either HCG or GnRH, depending on the protocol you have used, to cause ovarian stimulation. Shortly after the ovarian ovulatory trigger, which is then is the time for oocyte pickup. After HCG or the trigger is given, ovulation is expected to occur averagely about 36 hours after the trigger. So we aim to do our pickup between 34 to 36 hours after the trigger in order to, prevent going too late and the woman having ovulated before you get there. Then the next stage takes us to, the laboratory procedure where, that's the oocyte assessment, oocyte preparation, sperm preparation, and the fertilization process, depending on sperm quality or the background history of the patient, which is followed by embryo transfer. Embryo transfer is usually done 2 to 3 days, 2 to 5 days after oocyte pickup. We have the 2 transfer, the 3 transfer, which are the cliff stage transfer, or the blastocyst transfer, which is the day 5 transfer. Day 2, day 3 were the initial transfer date, and as development in ART continues, culture medium, better culture media were developed that could grow the embryo to the blastocyst stage in the incubator before transfer. Of course, we cannot do beyond the blastocyst stage, because after then comes the hatching, and the embryo is actually supposed to hatch where it should plant, not outside the endometrial surface. Okay, following embryo transfer, now comes the luteal support. That is because most of them would have gone through some period of downregulation or have used some antagonists, to suppress the pituitary. We want to support the initial pregnancy period, particularly the first trimester, with progesterone. So luteal support and pregnancy test is done 12 to 14 days after the embryo transfer. That is comes the judgment day. And that's the day that most of us dread, because while some are jubilating, some are wearing long faces and asking you questions despite all your counseling at the initial phase. Now, let's get down to where do we come in? The male factor, because in IVF, we discovered that male factor actually is more rampant than even you, the urologist, see. I might say so, because initially we never thought it was that much, but what we're seeing these days, male factor is virtually almost at some point taking over much more than the female factor infertility, particularly people coming for IVF, except for those who have gone beyond their reproductive prime. That is when menopause is setting in and ovarian reserve is gone. So surgical sperm retrieval becomes very important for us, for people who have obstructive exospermia, and even sometimes with non-obstructive exospermia. There are some people who still have some foci of spermatogenic cells. And all we need is just a few, even if it's spermatid, we can actually use it for ICSI. And failure to ejaculate during the procedure, and you wouldn't want to allow the cycle to waste or the egg to waste, even though we have facility for cryopreservation now. And sometimes people who have atenospermia, it is thought that if you go into the testes, you might see the ones that are more viable than doing them outside. What are the techniques available for surgical sperm retrieval? It's very, very important. We have the MESA, which is the microsurgical epididymal sperm aspiration. Time will not permit me to go through the details, but this becomes very, very key because it involves the use of operating microscope, and it gives you an opportunity to see pool of spermatozoa that you can even preserve for future use. Then we have the open fine needle aspiration, which is getting sperm from the epididymis after some level of exposure without actually, going too deep. Then the percutaneous epididymal sperm aspiration, which is the PISA, is the most common one we do, particularly in most IVF centers. I personally had some training in surgical sperm aspiration because the ideal thing actually is a collabo. We're supposed to have a close relationship with andrologists, urologists in the center. Any IVF center actually is supposed to have an urologist or an andrologist that, that work very close, to take care of some of these things. But you agree with me that even among yourself, you know that you're not enough, not to talk of coming to sit down in one small place, we call it, and be waiting for one IVF expert to call you to do some of these things. Now, TISA is the testicular sperm aspiration, going directly into the testis to aspirate sperm from loculi of a sperm collection. Most of the time, we get spermatids from TISA, and we have a needle aspiration biopsy, cutting needle biopsy, and then we have the open testicular sperm retrieval. At this point in time, I want to pause and say something before I forget. Most of the time, I talk with my urologist friend, when we try to do sperm testicular biopsy, so to say, these days we advise that if you're doing testicular biopsy it should really not be too much of a diagnostic process. We should do it in collaboration with anywhere that there could be an IVF center where, such sample that is obtained, if their sperm cells can be frozen, can be stored, for future use, rather than, just go to make diagnosis. And, if there are sperm cell indeed, and the patient is coming for the retreatment, when you want to do your PISA, there might be fibrosis that could make harvest more difficult. Commonly used of this method, I've said in order of simplicity, is the PISA, the TISA. The TC is the sperm extraction, which is akin to the testicular biopsy. You take a chunk of tissue, and from there, you extract the sperm from there. Then the MESA and the micro TISA, which is actually, the micro TISA is one of the technique employed for people with non-obstructive azoospermia. Non-obstructive azoospermia. You go into the testis and begin to search pockets and loculi of where you can get sperm cell. Well, improved method in vitro fertilization as it concerns male. Somebody talked to us about CASA. I know CASA becomes very important in IVF ICSI because apart from just sperm analysis, it also categorizes sperm to give us idea of what treatment modality to use. Should we inseminate or should we do ICSI? Because some sperm could just be normal in count, normal in movement, but if the speed of trajectory is low, and you do conventional insemination, you might end up not having fertilization. So to advise you to do ICSI rather than conventional insemination. And ICSI come into play, to help us with very, very poor sperm, particularly very low sperm count, where you take one sperm for one egg. Then further development was the IMSI, intracytoplasmic morphologically selected sperm injection, because where we have very bad sperm quality, it becomes very difficult. Fertilization rate is low, so you need to screen the sperm through and through before you select the sperm that you are going to use for injection. Finally, we talk about the genetics in IVF in terms of male factor advancement, particularly people with very aneuploid, people who have genetic disorders, particularly the balanced translocation, it becomes very important to do pre-implantation genetic testing, even on the embryo after fertilization, to screen out those embryos that are bad, rather than going ahead with doing embryo transfer. I will want to move to the next topic, which is the ethical issues in sperm and ovum donation, which is gamete donation. We try to concentrate on ethical issue here because there are so many issues that surround gamete donation. Gamete ovum donation has become more common and is beginning to increase. Awareness, and people are beginning to accept it, as a way of, helping out in infertility management. Recommendation and guidelines concerning gamete donation vary from country to country and between professional groups even within countries. And some countries do not even have any framework like ours. There's just nothing standing, no legal framework, no ethical framework, just that, now a lot of bodies like AFRH and, fertility bodies are trying to build a guideline, because people are doing whatever they like. Their cultural beliefs, religious beliefs, legal issues, and ethical issues are bound when we talk about ovum or gamete donation. But we shall consider just a few ethical issues, and we'll leave the rest to discussion. One of the major ethical issues is the issue of disclosure or non-disclosure. Disclosure means information about the female or male infertility will be communicated to the child that is resulting from this donation program. Should we disclose? Should there be disclosure or non-disclosure? It has been a matter of debate, but in the developed world, the disclosure have, really taken over the day. The people against disclosure say that it may jeopardize self-image of a person. It is the right of the gamete recipient to shield their privacy by non-disclosure. Everything is done in secrecy. You don't want anybody to know what you're doing. So why will you now come and begin to tell the child that, yeah, this is what happened, this is what happened? However, it is said that disclosure in this instance is a closed one. You are just telling the child, you are not going to announce it to the open, unless the child wants to begin to say it out. That is thought that in the long run, the readiness to let know that donor conceive will lead to a greater, to let the person know will lead to a greater societal acceptance of donor conceived children. That's where they are pushing towards disclosure. Let it know, nobody can harass you, nobody can go under to say this and that behind you. The next issue of ethical concern is the issue of anonymity. Anonymity of the donor party, the person donating. Yeah, that is of, should it be anonymous or should it not be anonymous? Should it be known? These are things that are very, very key. That should the offspring be informed of their genetic or biological father and mother, or at what age should this be done? If you say, okay, anonymity should be removed. Okay, now this offspring have known, you have disclosed that, oh, I'm a product of a donor gamete. Okay, now, should I know who the genetic father or the genetic mother is? That's the next question. If yes, at what age am I supposed to know? So all this brings a lot of problem. The donor may want to know the recipient, and the recipient may also want to know the donor. So this goes in both ways. And the offspring may later inquire about the identity of the genetic parents. The arguments in favor of anonymous gamete donation, says that telling the child of his or her birth by sperm or ovum donation may subject such a child to social or psychological disorders. That anonymous donation allows parents to maintain absolute privacy. Most often, the rearing mother is the owner of the child in the case of, if her egg is used, in the case of a sperm donation. And the father may now see himself as a vessel to just satisfy others, and the other way around. In case of ovum donation, the female partner may consider herself just as a mere gestational carrier to satisfy the male partner. Then the non-anonymous gamete donation. This is the trend now in Europe and America, because everything is known, is everywhere, that hiding such information, the proponents say hiding information from a child will result in child violation of the child's autonomy. You see, we're talking of human rights now and everything, that the child must know. And the child must even know the person, the parents, you know, that the child barred from the knowledge is likely to face mistrust, false self-perception, and feeling of sadness and puzzlement, you know. So a lot of psychological and social issues coming into this, that knowing one's genetic origin is an integral part of forming one's identity and an image of oneself. You know, the first country to actually support this, particularly for sperm donor, is Sweden, and so many other countries have embraced it. But we should know that in countries like ours, where there's no legal framework, no social framework, you know, non-anonymity, you know, causes a lot of problem. It leads to sometimes extortion, exploitation, and you know, because the person who donated will come and be touting you here and there. There is a case that we're involved in, where I worked previously, where a sister donated to, I mean, somebody, a family relation donated to a sister or a cousin or something like that. And eventually they had a baby, egg donation, and the woman passed on, you know, because the man had some money. The sister who donated came forth and said, it is her egg, that's her baby. I want to claim the home. You know, that ended up as a court case and were called as witness. And that's what resolved the issue because of documentation and consenting. The other ethical issues are those of age requirement for gamete donors. What is the right age? You know, it varies from country to country. In the UK and Canada, age 18 years and above, you know, once you reach the legal age. In US, for sperm donation, they peg the age at 40 years, you know, and in a country like China, 22 to 45 years. And maximum age limit for ovum donation generally is pegged at 35 years because the incidence of aneuploidy increases exponentially after 35 years for women, you know, but higher for men. The other one is limiting the number of offspring. What is the, can somebody continue to donate and donate and donate and donate? It's a question, because this, the risk and the danger of that is the issue of consanguinity, you know, that's accidental consanguinity. You now have people of the same biological origin having to marry themselves unknowingly because of incidence of donation. You know, particularly in an environment where there's no statistics, there's no record keeping, even over there, even where there's record keeping, you don't follow them about, you know, to tell them. So the American Society of Reproductive Health therefore suggests that in a population of 800,000, limiting a single sperm donor to not having more than 25 births would avoid significantly the risk of accidental consanguinity. A lot of researches have been done, and most researches come forth to say that bringing the risk of consanguinity to very, very minimal will limit donors not to have more than 10 offsprings. Minimizing risk of infection and genetic disease to gametes from the gamete donors is one ethical issue. So a lot of screening, history taking, and even genetic screening have been advocated. Then client's rights. It is the right of the recipient, you know, to have enough information about where the source of the gametes. Then the ethics of choosing of sperm or egg. You know, there are some sperm banks, there are some donor agencies who put so much of a bar, you know, because they want to put so much of cost somehow to people who are coming to receive, you know, to the point that, you know, there's a bank in Germany that one time say only accepts sperm donor from Nobel Prize winners. How many Nobel Prize winners will come and say they want to give their sperm, so that anybody that is coming to take such sperm oh, they can put such a high premium on it because the compensation too is high. Then does a sperm donor have the duty of a father? That's another big question, where there is disclosure, where there is non-anonymity, So it is actually said that, to prevent this, it has to, the donor has to go through a legal pathway. I mean, that's a recognized pathway, go to the cryobanks, recognized cryobank, where necessary documentations are taken to absorb them from taking any duty. There's a popular case which was won by a couple who separated after sperm donation, and the woman had custody of the child, and the child had a medical issue, and he had to go back to meet the donor, not the husband that is separated from, that is the biological father, to come and pay medical bills. Donor compensation and the morality of payment is another big thing. What constitutes compensation? Is it for sale? Are we commodifying these issues? Are we trying to help out? These are issues that have really stirred a lot of ethical issues. But in the UK and part of US, particularly in UK, it is said that compensation for lost time is what is being done rather than outright sale of egg or sperm. It is easier for sperm donation, but because just an ejaculation. But for egg, before you get to donating egg, you have to go through series of checks, series of injections. You have to go through invasive, semi-invasive procedure of egg retrieval, So all these, are put into place. And this sometimes can cost up to even $5,000 in terms of compensation, averagely $200 to $1,000 for some, depending on, the race, the kind of person, educational background, and all whatnot. In conclusion, what must donor consider before you go to donate? Why they agreed to help the recipients. Who will have access to their garment? They must consider all those things. And how many families or offspring they are willing to help conceive, and all not. Then the recipient on their own side will also consider a lot of things. Whether their fertility situation has been properly assessed. Somebody talked about false positive assessment the other time, a false negative rather. What they will tell the child, they have to agree all these things. Then whether their partners have agreed to use donor gametes, not just a forceful thing on them, and the extent of interaction they want the donor to have with the child, and what they will do if the donation process fails. The ultimate goal is to help infertile couple conceive healthy children, and all measures should be properly directed towards achieving that. Thank you very much.
Oh, thank you very much, Dr. Onu. And thank everyone for remaining intact and so fixated to the discussion. I think there are comments on the chat box, and then we'll look at some of them quickly, and then
please Dr. stop sharing your screen.
Oh, sorry. Yeah.
Oh, is that somebody else?
No, it's okay.
Okay. So let's look at the chat box. It says, I'm intrigued on the effect of use of cell phones in male infertility causation. And they wanted Professor Okeke to kindly throw more light on this. But there was a subsequent comment whether this is really the use of cell phones or laptops that are placed on the laps. So Professor Okeke.
Thank you. There are actually several studies on this issue, this topic now. And the studies are concluding that this damage occurs in two ways. One is the electromagnetic emissions. Some people have actually studied the effect of the electromagnetic emissions on the spermatozoa in vitro. And they cause sperm damage, reduced motility, and chromosomal injury damages. And the second aspect is heat. So apparently, it has to do with proximity, with the phone being close to the testis for the emissions to have such damaging effect, and for the heat produced to also raise the peritesticular temperature. Laptops will cause a similar effect when they are on the laps, but through heat emission. So the phones do it through electromagnetic waves and heat. The laptops through heat. I suppose that answers the question.
Yes, yes, thank you very much.
The results, the publications are available on Google.
Okay, so both of them have an effect.
Yes, sir.
And then to Professor Ahmad, that's okay, I think I wrote that comment. Can you actually resect the ejaculated ducts without resecting the verum montano?
Well, thank you very much for that question. If limited resection is done, because in patients who have medium prostatic cysts or ejaculatory duct cysts or Mullerian duct remnants, sometimes limited resection may suffice to open up the obstructed ejaculatory duct. And in such case, you may not need to have to resect the entire verum montanum, where on the summit you have the ejaculatory duct. The obstructed ejaculatory duct or medium prostatic cyst will not appear like the normal verum montanum you see when you do cystoscopy. Usually they are a lot bigger than that and more prominent. And you might even see the cyst bulging. And as such resection can be done without necessarily resecting the entire verum montanum. Yes, in instances where it is not possible to preserve any part of the verum montanum, yes, the typical thing is to do the third, the transurethral resection of the ejaculatory duct, which often will include the verum montanum in this case. Thank you very much.
Thank you. That's a comment. That was by me again. Dr. Onu, are we really saying that if an individual donates spermatozoa used to inseminate a woman, that this does not qualify for ART?
Yes, IUI, that's intrauterine insemination, is not ART technically. It is an assisted reproductive, other form of assisted reproductive enhancement. Because assisted reproductive technology, because there was a lot of controversy of what is the redefinition. Any procedure that involved the handling of ovum or embryo. So in IUI, there is no handling of oocytes. There's no handling of ovum. It's only sperm that is prepared and inseminated. So it is not technically an ART.
Okay, thank you very much. Dr. Aliu Siraj wants more information on the 2021 WHO SFA parameters. So Dr. Abioku, he needs help on that.
Okay. I thank you very much, sir. The 6th edition is actually out, which I'm going to share the PDF copy. So, but essentially, the main difference, that I was able to extract was just addition in the area of maybe sperm odor, and it dwell much, especially on the sperm DNA fragmentation. So, and also the recent development of the cryo preservation was also addressed so much on that too. So some of these genetic testing were actually discussed more in the new 6th edition. So the 5th edition that came out in 2010 has actually been reviewed. So, but that is the words I was able to lay my hands on. But the edition, the PDF version, is going to be passed across through the CME committee. And it's actually available online. Thank you.
Okay, thank you very much. We hope we get that copy. The next comments were by Professor Okeke and Dr. Nkama on the issue of cell phones and laptops. I think that has been answered. So we'll go to the next one. So what does the urologist advise? Limited use of, okay, this is still to Okeke. So should there be limited use of cell phone?
No, we shouldn't be talking about limited use of cell phone, but we should limit keeping it in a pocket close to the testis. All right?
Okay. Okay, so keep it as far away as you can. Not in your pocket. Okay,
Hello,
the
sir.
next comment.
Sorry, sir.
Me again. Yes.
Yeah, the urologist say don't keep it in the pocket. The cardiologist don't put it in the chest pocket. The ophthalmologist say don't put it close to the eye. Where do you keep it?
He said it's called a handphone, actually.
It's a hand
close.
It's supposed to be held in your hand, actually.
It's the women that keep it in the back. Okay.
It's supposed to be handheld.
Yeah,
and linked up with a device.
The plastic surgeon will say don't keep it there.
Yeah, maybe a plastic surgeon will say it might cause some depitrance contraction. Okay, the next comment was from me. Should the recipient of an egg or spermatozoa know the physical characteristics of the donor, whether he's fair, he is tall, he's short, he has a sharp nose? In cases of anonymous donation, should they ask for characteristics, physical characteristics of the donor?
Designer baby.
Okay. Yes. Yes. Anonymity does not preclude knowing the characteristics. So they have the right. I mean, they need to know the specification of what they are going into. Is it fair person? Is it, because a fair person will not come and keep quiet and will not deliver a baby that is dark. You know, it becomes something to. I have a patient one time that went to India and needed sperm donation. They said they have black people. Yeah, so she did. And when she came with the child, she can't move anywhere because, you know, the child was a black Indian with long hair to the down. So it's not what, if they had told her exactly that, look, even though it's dark skin, but the physique is going to be Indian physique, I'm sure she wouldn't have accepted. So they have the right to even specify what they want. But the anonymity means you don't know the person and the person doesn't know them, no contact yet.
Okay, thank you very much. The next question was from Dr. Hassan Dogo, and he thinks that NAUS should sponsor a bill on this ethical issue so that everything will be guided by the law. Our president, sir. Well, what do you think of that? Oh.
Is the president on the platform?
Okay. Is president there?
No.
I can see Warford smiling and then
yes, Warford is there. I've allowed him to unmute himself. Professor Warford, you can unmute yourself.
Yeah. Good evening, all. I think the main problem we have is that there are no guidelines for anything in this country, no legislation. And you see, this is beginning to be a regular practice in this country. Now, you know, the issue of assisted reproduction. And I think there's need to push for proper legislation so that we can actually practice safely. We should, I think now we should really think about it. We can also join with the gynecologists. And then we can, when we have had the draft and looked at it properly, we can then see how to push it through the Assembly to make it a law. There must be control because you see, we don't even know what each person is practicing. Thank you.
Okay, thank you. I think the Renal Transplantation Society is going through a similar thing.
Yes.
To have some ethics and laws for the country. So that would
but
be
we had a lot of problem in that renal transplant because I was an interim chairman for the health committee, for the what's the full name again? Health Act committee on that. Yes, we were inaugurated. There's nothing we didn't do. Even the Turkish group wanted to assist us to develop even both the registry, help us from everything. But in the ministry, they've actually killed it. We never met. All the human rights people, everybody continued to write me letters as if I was the person responsible. Eventually, our tenure finished 3 years and we went off. And since then, there's no other appointment for anybody. So it's very, very unfortunate. They're not helping us at all in any form. We need to legislate and have control of the things we do so that there will be a standard for the country. Thank you.
Okay, and Dr. Dogo, has this to say that must a couple have to wait for 1 year and above before they are said to be infertile? We're looking at definition now. So any of the discussants?
Okay, yeah.
Sometimes we don't. Sometimes a couple has been cohabiting actually for a long time before they now say, I do. So for such people, you don't have to start counting from the day they say, I do. To start counting from when they started living together, when they started trying. But typically, if in the normal marriage, you wait for 1 year.
Okay.
Okay. If I may add something on the women's side, because the law, the general rule, there was a caveat for people that are above 38 years of age, because their time clock is going, we step them down to 6 months rather than waiting for entire 1 year. And there are some people who have recognized problem even before they get married. Such people, there's no need to wait. Like somebody who have had 2 ectopics and 2 tubes are chopped off, or a man who probably had some testicular injury. I know there's a problem, So I think those are just the little, but generally the 1 year rule apply, but there are exceptions.
Okay, so other comments and questions, I will wait for people to raise their hand and we recognize them. But I want to bring up an issue on the etiology of infertility from childhood surgery. That's a common thing. I don't think that in a child that we need to do herniatomy, that we should do it, that it's necessary to do it on the same day. And then secondly, I don't think urologists should do the practice of having to deliver the cord in a child when they're doing an inguinal surgery. Just leave the cord alone. Find out where the sac is and pick only the sac. In the process of delivering cord in children, as we do in adults, we actually devascularize their testicles, and then we have problems. And that happens if we have to do it by a bilateral case. So I think as urologists, we should be careful. If we go to the groin of a child, we should try as much as we can to avoid delivering the cord. Just pick the sac wherever it is and deal with it. That is my own personal opinion, but because sometimes these things are overlooked. The child has had such surgery as in childhood, and then as an adult, there's problem of fertility, and we don't seem to link it back to what happened. So the more we avoid delivering the cord, I think the better for the child. Okay, any questions? Somebody to raise hand.
There's a question on there's a comment on the chat.
Okay, comment on the chat. Let's check it again. Yes. Okay, Eva said, what is the position on an unmarried woman receiving sperm donation?
Well, okay, let me take that.
Okay. Yeah, because yes, go ahead, because I'll make my comment later. Go ahead.
Okay. No, I mean, when we talk of, because we don't have any legal framework or guideline, but I'm using global best practice, the people, the rights of reproduction, of right of everything, that a woman is unmarried does not prevent her from being able to conceive if she wants to. So if you're an unmarried woman, suffice of reproductive age, of legal age, wants to conceive and want a donor sperm, is lawful, and nothing stops her from doing that.
Yeah, I was going to say that. Thank you. I was going to say that it's like asking an unmarried woman going to a man to sleep with her so she can be pregnant. But that's similar. Just we can't prevent that. This is Eva. This is not church. Okay. Any other comments? Oh, Eva, are you satisfied with that or not?
No, this is an academic program.
Yes.
Not a church program.
Okay, any comments? I'm not seeing any hand up. And then no comment on the chat box. Then, okay, let me thank all the discussants and then the participants who stayed on to the end. Somebody has posted something which I will read. It's Okoro. He says, do urologists in Nigeria still do diagnostic testicular biopsy? Well, the question is open to everyone. I would believe that where people don't have facilities for other, and that might be the only thing available to them, of course they will do. But like we are told today, if you are doing something like that, it's better to do it where there's a facility with the gynecologist, with the reproductive specialist, so that you can use that same sitting to achieve more than one thing, instead of just going for diagnostic testicular biopsy. I hope I've attempted. Ekoriwo's hand is up, so he may want to make comments.
I've been able to. They can make comments.
Okay, Okoro, you can unmute yourself and make your comments. You have to unmute yourself first.
Unmute yourself.
Unmute now. Yes. Good evening, everyone. Yeah. Good evening, everyone.
Yes.
Good evening.
Yes, you know, it used to be a popular a procedure where we were in training those days, that you see our list, testicular biopsy, and that is one of the questions I asked myself there. What is the essence of this testicular biopsy? So when I arrived in Lagos, for example, I did a retrospective study of all the testicular biopsy, and I found that we have maybe like 5-7% of cases of obstructive azoospermia among those who had testicular biopsy. So it was a useless procedure. And the recommendation was, do not do testicular biopsy. You don't need to differentiate between, I mean, if you can't, just like Bilko has presented, if you can't use the hormonal parameter, the testicular size alone to differentiate between obstructive and non-obstructive azoospermia, just send the patient to where the patient at the IVF center, where if you do a testicular biopsy, you can make use of the spermatozoa that you may get for ART, you know. So I think it's something that we should discourage, and no urologist should just go ahead and do that diagnosis testicular biopsy just because you want to make a diagnosis of obstructive or non-obstructive azoospermia. I think it's something we should preach and something we should let everybody know. That's the opinion.
But my own comment would be, is it only to differentiate between obstructive and non-obstructive? I agree that we should do it where you can use the opportunity to achieve other things. But is it only for obstructive and non-obstructive? There was another hand.
Well, I'm sharing maybe I'll put it in the NAUS platform. What Bioku has just sent.
Okay.
I'll send it on the NAUS.
Any other hand that I can see? Okay, I think I would thank everybody who has stayed on to the end. Is that Linus raising his hand?
Okay, yes. Let me. Okay.
Yes, I think in addition, if one has made a diagnosis of obstructive azoospermia, before going ahead to start trying to identify the site of the obstruction, we should confirm that the test is actually functioning. And the testicular biopsy, the way we normally do it, it should not interfere with further function of the test, because the sample we collect is just like the tip of a biro. I mean, the head of a pin. It's not like we do wedge biopsy of the testis. So if going by hormone profile and whatever other parameters, we have concluded that this patient probably has obstructive azoospermia, before we now go ahead to start doing vasographies, which are much more involving, we should get a confirmation that that test is actually functioning. Thank you.
Yes, sir. Yes, sir. My point actually is that the current guideline is that you do not go ahead to do a diagnostic testicular biopsy. You know, if you are not planning to use whatever spermatozoa you find for IVF, you know, if it is just for you to make a diagnosis and then you send the patient, there is no indication for that anymore. So in our urologic practice, and that is something we should stop. We should stop doing, because it doesn't help us. Even when we now make the diagnosis and we say, okay, it's obstructive azoospermia or it's non-obstructive azoospermia, we can't help the patient even there at that point in time. So I think we should stop that kind of practice. That's my own opinion. And that's why I wanted to know, do we still practice that? Because in my own unit, we stopped that more than 15 years ago. We don't do diagnostic testicular biopsy.
Sorry, my network took me out. Okay, thank you, Okero, for the comment. Professor Okeke's hand is still up. Host, please, can you allow him to unmute himself?
Yeah, I've given everybody access to unmute himself.
Okay, Professor Okeke, I thought I saw your hand.
Our time is up.
Okay, our time is up. My duty is to thank everybody again for attending this seminar. So I thank our hosts, thank our guest discussants from ONG, and over to you, our chairman. Thank you.
Thank you very much, sir. My able moderator and the wonderful, wonderful presenters and our hosts, ever diligent hosts. Well done. And thank you for all those who have waited patiently and listened patiently. May I request that all the trainers and residents here tell the residents to be available for the one for next month. Next month is urethral stricture, the big one. I'm sure that the secretary of the West African College, the Faculty of Surgery, and the national people, Ajibola Jeje and Co, I will be very interested in residents attending that program. Thank you very much. God bless you. See you next month.
Yeah, thank you, everyone. Bye-bye.
So Ahmed wants to announce something.
Secretary.
Ahmed is muted.
No infamy. Yes. I'm just waving everyone. Bye-bye.
Okay. You are waving to your subjects.
Thank you, sir.
Okay,
Well
we have, you will check Nau's YouTube. Maybe by tomorrow or later this night, you will get this, the recorded version.
Please send us the link along with it too. With this now YouTube, you find out.
No, just type Nau's YouTube on your YouTube channel. You will see the last. But I will, once this finish converting, I will share it both in the Naus and then in
the. Ahmed, when are we? Okay, now that we have qualified to issue TME, we should start. You should be sending us the list now.
And now, so we are not qualified to issue CMEs.
Yeah. So we need to be having the list.
So that's why everybody should use their names. A lot of people use something.
Well, if the person uses another name, the person is on his own.
Somebody use
FMC.
Nkama.
Well done. This has really been exciting. Thank God for having the ONG person. You can see, make so much difference. You learn so much.
Yep.
Hey, Kayama.
All right. Good night.
Thank you. Hey, Kayama, show yourself. Unmute yourself. And show your face.
Here I am. Thank you to all our able club. It's been a beautiful interactive session. We still have many more questions to ask, but we've learned quite a lot. I hope I will be aware of your next session so that I will also join.
Yes, I will be posting it in the platform. Thank you.
Thanks, sir.
Thank you.